Welcome to our monthly webinar on trending beyond COVID-19. This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare. Sorry for this slight delay. We had a little technical issue, but I think that's been resolved. This session is being recorded as always, and during the webinar, you'll be on mute. Please submit your questions using the Q&A function in Zoom, and we'll answer as many of them as we have time in the hour that we have allotted for the webinar. We'll be posting the recording on our YouTube channel, and a transcript of the Q&A segment will be posted on our website within the next few days. You can find it on the COVID-19 landing page. In the interest of time, I'm going to turn it over very quickly now to our presenter, Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's also the lead clinician for our COVID-19 response. And now I'll turn it over to him. Thanks again for joining us. And don't forget, we'll be back for the next session on December 1st. So mark your calendars now. Dr. Harris.
Excellent. Thank you, Karen. And thanks everyone for joining again here this month. We have been talking about the real cost of COVID-19, right? And as you know, things are continuing to evolve in regards to particularly the emergency temporary standard. And we want to talk about that today. So today I'm doing what we have only done once before. This was last year, in that we're going to remix the meeting here today, the presentation today, and we're going to spend the majority of the time today answering questions. We did this, I think, in the fall, around the same time last year, and there was a tremendous benefit in terms of getting through all the questions that you had then at that point with the unknowns. What we are encountering today, obviously, and as soon as being published this week, is the emergency temporary standards from OSHA. There's a lot of questions around it. There's a lot of unknowns that they're leaving, that has left employers wondering how to solve the issue of being compliant versus protecting the workforce. And so we're going to dig into that a little bit here. I want to share with you an approach that we've crafted to really understand and digest how much should you be investing in terms of resources in your program to help with the ETS compliance with OSHA. At the end of the day, it looks like from all the indications that we've seen that the ETS will be enforced, that OSHA has already reviewed the ETS from the Biden administration and has given a green light to move it forward. The intel that we have and data that we've reviewed suggests that they were only waiting until after the round of elections that we know occurred yesterday to actually publish the ETS. So we do believe the ETS is imminent and will be in play here in the days to come. So with that being said, I want to talk about the philosophical approach and maybe not so philosophical, but even practical approach that we've had in discussions with employers over the weeks here. And it really is. So we're not going to do the traditional, approach to this webinar today. We'll get back to that next time, and we'll talk about the business case. But I thought it'd be prudent to really get at how should you be thinking about the ETS and compliance versus protection, and then also getting into the questions that you may have around the ETS and understand what we should be doing from an approach standpoint with testing, et cetera. So with that being said, what is the strategy that we should be taking in regards to level of investment regarding compliance and worker protection? Now, these two concepts are not mutually exclusive, right? They are definitely something, it is definitely something that we can talk about in regards to protecting the workforce as well as helping the enterprise move forward here in regards to our approach to ROI, right? And so if we think about the approach, it all begins with the incidents locally, and this is our approach, right? So there's a level of compliance that every employer with 100 employees or more will have to abide by, right? Either you're going to mandate vaccinations or you're going to allow testing on a weekly basis to be in place either at the work site or remotely, right? And so if we think about this level of compliance as kind of the baseline here, right, then we need to think about then two dimensions, right? Cost obviously being one of them, and then the incidence at the local level being the other factor that predicts how much we should invest above the level of compliance to protect our workforce, right? And if we look at here on the x-axis, the return on investment, that's what we want to be thinking about in terms of our level of investment above compliance. And if we look at that concept here in terms of the curve, we think about it in regards to this is the zone of additional protection that we can provide to our workforce. And we may consider this in the scenario in which it will provide significant ROI to the enterprise. Now, I'm not for a minute suggesting that we don't do our best to protect our workforce, but I am speaking to the practicality of how far do we go above and beyond compliance of the ETS to protect our workforce in terms of investment, because obviously our roles in EHS is to help the enterprise from a risk mitigation standpoint, and cost is one of those factors in that risk mitigation. And so we consider the volume or the area under the curve here above compliance, the enterprise risk benefit, right? And so put another way, if you look at the curve in terms of above the compliance level, there is diminishing ROI for your enterprise if you invest above compliance if the local incidence in your community is low. Now, let's talk about the data around community transmission. As of this week, we still have over 88% of counties, according to CDC, at the medium or high risk level for transmission, meaning that 100 or more transmissions are happening, or positive cases are happening per 100,000 in that county, right? And so it is critical that you look at your particular data at the county level to understand what the local community incidence is. And again, we see it across the board, on both sides. Those employers who are in an environment where they have low risk transmission in the community, and their investment strategy should be different than those employers that have a population in a higher risk scenario or community, right? And that's the enterprise risk. So now on the other side of this, right, if we have a scenario in which compliance is the same, we look at investment and costs, right, and we look at the curve here, the enterprise risk, right, is greater. And the potential ROI for investing above compliance is a better scenario, right, for protecting the business concerns, right? And so let's give practical examples to this, right? So let's say, for example, your operations can be hindered by one or more employees being out as a result of COVID. Then in those scenarios, right, you want to make an investment above compliance from the ETS to benefit and protect those workers so that you are mitigating greater risk from the business standpoint operationally, right? So that's a classic example of when you want to go above compliance to protect the workforce from a transmission in the workplace. Now, we know that community transmission by far does happen in the household, right? Those household members that are ill that communicate COVID to your employees, right? And controlling that is difficult. Speaking to that and educating to that will be key to helping benefit the workforce from that perspective. But again, in the workplace, those measures that we take should be measured again with what is the benefit to doing more. And so what I'm suggesting is that to be compliant, right, we know in the ETS, the likelihood that we're going to see specificity to a particular test, meaning should you be providing PCR versus rapid test, antigen tests, That won't be the language in the ETS, right? Any approved, we know that there's been communicated, any approved emergency use authorized tests can be used to provide compliance for your workforce for the ETS mandate, right? But again, if you invest in versus an over-the-counter antigen test versus a PCR test, there is clearly a distinction between what level of protection you're providing because of the sensitivity and specificity for your workforce of that test for your workforce. And that's what we're talking about here. Should you do more? Should you need to do more to get better ROI long-term, more broadly for the enterprise in regards to being compliant versus level of protection from a environmental exposure standpoint, right? And so those are the questions I want to begin to answer and get at, because there's still a lot of unknowns, right? In terms of how do we deploy this as an enterprise? Do we outsource? Do we insource? What are best practices? Those are all things I want to speak to, but I want to hear your specific questions. And that's how I want to spend the time today, because again, ETS is going to be here very soon. It looks like the courts are not going to be able to stop it. We do have cases in Chicago, right, for example, where a judge has filed a restraining order on the mayor's mandate for vaccination of the public workforce. And we know that it only applies to police officers. So even when there's an injunction in place, we know it's not across the board with all workers even in the public domain. And so this private domain ETS mandate is likely not to be stopped or stalled by the courts, and it is imminent. So with that being said, let's jump into questions. Karen, I know this is kind of a heads up here, audible, but I think it will be very beneficial to go through some of the details that we believe to be best practices at WorkCare around the ETS and how to move forward with compliance versus protection and some of the rules that we're seeing come out. So
Okay.
let's jump into it.
I can handle the audible, and I'll be moderating your questions, folks. So please use the Q&A function. If you use chat, we can monitor that too, but it's a little easier if we just use the question and answer. Dr. Harris, maybe you could hit some of the high points of what is going to be contained in the standard. We've already seen drafts of it, but what do you think are the most salient aspects of it that are causing confusion?
Sure. So it is around cost is probably one of the most prominent ones, right? Whether or not an employer will have to bear the cost of weekly testing for the unvaccinated population in the workforce. And the answer to that has not specifically been called out, but we know that the cost can be passed through to the employees. And that particular issue still doesn't have a clear approach, and from a strategy standpoint, outside of the level of competitiveness of the job market in which you have your business, right? And so looking at the turnover rate and then looking at the job market in general will help inform you whether or not your enterprise, your company should pass that cost on to your employers. And this is putting on the MBA hat, right? So if you have a competitive environment, now asking the employees who aren't vaccinated to pay for their own testing, which is permissible according to not just the mandate, but even EEOC is suggesting that as well. It will set up potentially a scenario in which it makes it more difficult to retain employees in that environment, right? And so what we've seen at some employers is that they're just bearing the cost. And as we're talking about the true cost of COVID, right, bearing the cost of the test for the weekly testing regimen. And the next cost-related issue in the ETS that we've seen, drafts that we've seen, is the mandate to provide paid time off to your employees to go get their vaccine. That's going to not, I mean, you have 100,000 employees, that's a significant cost, right? In terms of the time away to go get vaccinated. And when we talk about then the follow-up to that, we know that paid time off will be on the employer for any reaction to the vaccine. So you are on the hook for making sure that an employee is paid to go get the vaccine. And if they fall ill or have side effects, right, from that vaccine, then they continue to have the paid time off from the employer. That's a huge cost potentially, right, to our employers. And the difficulty that in that is discerning, right, who has a response. So we've been doing a lot of servicing of employers to provide their screening for symptomatic disease, right, for COVID. In doing so, we've also seen the response or side effects from the vaccinations, and also provided and recommended that an individual be off work while they're having a response to the vaccination. And it's something that as an employer may be tremendously burdensome, if not difficult or impossible to do at scale for a population of workers that go get vaccinated with paid time off and then claim to have a vaccine response, right? How do you validate that? How do you ensure that it's not just individuals that are leveraging the opportunity to have some paid vacation after their vaccination, right? And so it's something that we've been dealing with for months now, and been able to ascertain using, again, our clinical judgment of the consistency of what they're complaining about doesn't vibe, doesn't add up, doesn't make clinical sense, and then recommending, look, either go to your PCP and get some objective clinical data around the response that you're having to the vaccine, if there's truly a concern. And if not, we want to then document that and hold that as PHI, right? So that we have a clear paper trail of an individual's response to the vaccination. So these are all things that the ETS is saying it's on the employer to bear the cost, but there's no systems in place to help you identify where those costs should be allocated appropriately, so that we limit the gamification of the mandates from a vaccination standpoint. And again, we've been dealing with this since vaccines have been available, but it's going to be a tremendous burden at scale because of these mandates. So those are some of the high points. I can speak to a couple more, but if there's any questions around those and that piece of it, we can answer those right now.
Yeah, let's jump into the questions. Just to reiterate, the first question is, if weekly testing will be an option, what do you think about passing the cost onto the employee who is resistant to receiving the vaccine? So you just addressed that, but what do you anticipate is going to happen if the cost is passed on to the people who don't want it?
Sure. So we're going to see what we've seen already, right? The workforce leaving, retiring earlier, and potentially a scenario, a bottleneck in terms of providing services that all of our employers provide, right? We've seen it happen in New York, where we have the public servants. Although I believe it's 91% of the New York public employees have been vaccinated, right? Or at least received one shot, one dose of the vaccine. There's still 9,000 workers that have not. And even the police force in that scenario, firefighters in that scenario, they've had to close down several locations and not provide those public services. So we know that's going to roll into what we're going to see in the private sector, and many times fold in terms of, and we've all seen the unfortunate scenarios with the airline industry having delays as a result, potentially in part from the mandates and not having the capacity. But we're going to see that at scale with employees, right? Walking off the job or retiring early, and there being a bottleneck to provide those operations. And it's going to be something that is unavoidable at this point, unfortunately, in terms of the vaccine itself. We amplify that if we pass the cost on to those employees now, because we're providing the motivation to leave from a financial standpoint, right? Because the bearing the cost of that on a weekly basis in perpetuity. At this point, we don't know when these ETS will expire, right? And so if we're looking at weekly, a cost being added to the bottom line of someone's employment, it's going to be a disincentive for them. And unfortunately, that's just going to continue across the board. And states may fight it, but I think we have clear evidence that courts, again, won't be able to stop the ETS.
Okay, so you just touched on when we don't know how long the ETS will be in effect. Do we know what the projected date for implementation is?
We have language from the review that has happened at the federal level with OSHA to say that it's going to be immediate. Now, immediate obviously is still a window, but we anticipate that it's going to be as soon as this week, right? Obviously, I don't have a crystal ball, but the insights that we've gleaned from communications from Fed OSHA, it appears to be that it's going to be implemented in days, not weeks, not months. We know that there's been a petition at the federal level of several corporations to delay the ETS implementation to get past the holidays, which obviously is a peak time for temporary workers into the workforce, right? And this ETS may offer a disincentive for those workers to enter the workforce at the same rate as classically we've seen from a temporary worker standpoint. But it appears that the language being used in the briefs that we've seen it's clear that the review is finalized, the ETS has been finalized, and that it will be imminent immediately to be implemented.
Yeah, and they have a new director now who's overseeing this. So, and we haven't had a officially appointed director since 2017 of the agency. So
That's correct. That just happened this week as well. Absolutely.
right. Do you anticipate significant shortages in rapid tests and or PCR tests after the ETS comes out? And a supplemental question from another participant is, what is the anticipated range of cost for these tests?
Great questions here. Actually, let me see if I can pull up a slide or two to speak to that, because there is definitely anticipation of a demand outstripping supply scenario, right? If we look at the over-the-counter supply, it's already we've already seen that demand being outstripped, where you can't go in a lot of jurisdictions, you can't go to CVS anymore at Walgreens and get an over-the-counter test because the supply is not there, right? And so we anticipate that also being the case for our corporations trying to be compliant with the ETS here. So there are nuances to the approach, right? As I pull up this slide, let's see here. Give me 2 seconds and we'll, I think we have it here. So we want to talk about what are the options, right? So it's clear that, again, there is no specificity, and there will likely not be specificity in the ETS regarding should you use a rapid test versus PCR test, right? Any EUA approved test will be available. We know that manufacturers have tried to ramp up with these tests. We have seen a bottleneck for even our operations regarding getting tests out, but that has been resolved in the recent weeks. But that's pre-ETS, right? So we have companies that are buying tests in the order of magnitude of $2.5 million of tests, $2.5 million worth of tests at this point already, because they've implemented the mandate at corporate wide. And that's because they are federal workers, right? So that's one of the aspects that we know is also unavoidable. You have federal contracts, you are underneath the mandate at this point in time, and it will likely not be avoidable for federal contract employers, right? So we see them already getting behind weekly testing for their population that are not vaccinated, and we will likely see the similar demand strain happen here once the ETS is published. With that being said, again, and I apologize, the slide that I wanted to pull up here is not coming up, but it really is looking at the comparison between The classic testing that we have seen with regard to the rapid antigen test, the over-the-counter test versus PCR molecular tests, and comparing that to pool testing that's still available, right? We know that, here we go. So we know that pool testing will likely be something that is ramped up in the weeks to come as we look at the ETS being published. And I'll share this slide right now. Hopefully everyone can see that. So just a refresher, right? We know that pool testing is a way to mitigate costs from the perspective of providing molecular tests for the largest number of people on a weekly basis. And we've seen these companies provide elegant solutions to doing on-site pool testing. So we believe this will be, if the ETS is in place, for many months to come well into 2022, right? We anticipate that this will be predominantly the option that employers use for on-site testing, right? If you have a remote workforce, obviously pool testing will not be advantageous. The home test will be the predominant way we accomplish compliance there. But again, it is still an option. I want to be clear, it's still an option to say to your workforce, with what we've seen with the ETS, go get tested on a weekly basis and leave it to them to figure it out, right? But again, that sets up a scenario in which it decreases your competitiveness to retain talent, potentially if you're in a hot job market, if you don't provide solutions for your employees. And then it begs the question, right? If you do mandate employees that are remote be compliant with weekly testing and they don't do so, right? Is the employer now on the hook at non-compliance? Or is it merely the notion that you have a program in place, you have a system in place, and you have a way to deal with non-compliance internally before OSHA comes knocking, right? We don't know that so far. We haven't had the details in the ETS to understand when enforcement is at the door, right? OSHA is at the door to see if you're compliant, whether an individual's non-compliance holds the employer in non-compliance. And if that is the scenario, right, then you have to have a plan from an HR perspective at dealing with non-compliance. Do you dismiss workers like we've seen, right? Even in Chicago, the mayor has said, we're going to fire the public workers who are non-compliant. And so that needs to be a consideration for coordinating your reporting and your reporting for compliance with the ETS to your HR department so that you can quickly deal with non-compliance from that perspective. Again, additional costs.
I was just going to say, it sounds like a permanent employment plan for employment law attorneys. One respondent has said her company requires employees to pay for their own weekly testing if they choose not to be vaccinated. So I'm presuming in a case like that, they've conferred with legal counsel and been advised that that's an acceptable practice. But there's still a lot of questions around it.
Absolutely. And if they go get their own testing, then usually it's some type of attestation that workers will need to do on a weekly basis that they are compliant, they have tested for the ETS, right? And leveraging a digital platform is, for us, best practice, whether it's, as simple as logging it in your internal systems, SharePoint or whatnot, or if you're using and leveraging your HR and benefits platform, or if you're, looking to third parties, right, and to document and keep with compliance tracking for not just obviously the testing on a weekly basis, but for the vaccinations, right? All right, we're going to talk to this. I know this is throwing everybody for a loop potentially, but it's what's coming down the pipe, right? Potentially. We are dealing with now a scenario of the CDC, right? Because obviously the ETS will mandate you either comply with vaccination or you comply with weekly testing. That means you have to document your vaccinations, right? CDC and the director has suggested that they may redefine what it is to be fully vaccinated, the definition thereof. If we look at the data from Israel, we see that a booster, third shot, is necessary to get your immunity to transmission, contracting and transmitting COVID back into the 90s, 93%, right? At this point, it's dismal in terms of protective factor at transmission risk. Breakthroughs are tremendous 6 months after you're fully vaccinated. And 61% of the population after vaccination may still be susceptible to contracting and transmitting COVID. So we know that booster will likely be deployed or required for the entire population, right? It's not yet so. Only those individuals that have particular risk factors or occupational exposure. But we know that likely because of what we've done in terms of following Israel's lead, we know that we're likely to see CDC redefine fully vaccinated as 3 doses of the mRNA vaccines, Pfizer, Moderna, and a booster, particularly if you had Johnson & Johnson. They recommend already you go get a booster. There's no additional requirements other than you only had Johnson & Johnson, right? And so a third shot for those individuals who receive Johnson & Johnson will likely be required as well if the CDC changes the definition. And that sets up the scenario for our employers to then document that, right, compliance with being the new definition of fully vaccinated, as well as understanding who's still at risk for contracting and transmitting in the workplace. And then the mandate from OSHA to protect those who are vulnerable who can't mount a response from vaccination, immune response to from vaccination, right? So there's a lot of layers here that we're potentially up against, because not just because of ETS, but because of what we're learning from COVID and what we're learning from the evolution of our vaccination against COVID. And again, it's likely that these complications will be in play here very soon before the end of the year.
Okay,
Obviously,
so
and
go
real
ahead.
quick, I'll
Sorry.
speak to, obviously, we've all seen the approvals of FDA with children age 5 to 11, right? That's now, we're moving in the right direction in terms of vaccinating the youth, as well as the age group younger, from the Pfizer data to be soon released, from 2 to 5, it looks good, right? The immunogenicity, meaning that they're able to mount an immune response to because of the vaccine, is comparable to adults. The dosage is the difference, right? 5 to 11 get 10 micrograms versus 30 micrograms of the adult dose. From 2 to 5, they get younger than 5, they get 3 micrograms, but they've still seen the efficaciousness at protecting that population for at least 6 months. Again, their immunity wanes over time as well. So we're talking potentially down the road next year, boosters for your kids as well, right? And I, being, with a 4-year-old and a 1-year-old, am anticipating getting them vaccinated once the next tranche of data is given by the pharmaceuticals around the efficacy for the younger population and 2 to 5. So that will impact us from the workforce perspective in a positive way. Theoretically, household exposures because of the kids should go down and diminish. But it's yet to see the levels of response, right, from parents to sign up their kids. If we look at the data, we can see that the anticipation is a third of the parents will be in line to get their kids vaccinated. Everybody's anticipating a third of parents will wait for weeks, if not a month or two, downstream to see if there's any new data on side effects from the vaccine. And then a third of parents will not take their kids at all. No way, no how. In the polls, will they say they'll get their kids vaccinated? But the data is clear. Side effects are comparable to the adults, mainly just sore arm from the injection site, mild symptoms, very little risk regarding Pfizer with regard to myocarditis. The FDA did say they need more data on the Moderna vaccine, as you may have seen, before they approved that for the 5 to 11-year-olds, because of the risk, most likely, of myocarditis. They just want to examine it. Doesn't mean there is increased risk, but they just want more data. So we anticipate these things will be in place definitely before the end of the year for the almost entire population from 0 to adults to be vaccinated and boosters as well.
Okay, so perhaps you could opine a little bit more on the vaccine in response to this question, just from a clinical perspective. How is it legal to mandate an experimental, unproven vaccine?
Sure. So this vaccine is not so much experimental in that it's novel, right? The first time we've done mRNA vaccines, but we also have traditional, in the case of Johnson & Johnson, adenovirus produced antibodies, right? Or vaccine to produce antibodies. So these vaccines aren't all novel experimental. They are novel in terms of it's to address a virus that's new and novel, but we know that this is not anything new for us as a society, right? Circa smallpox, circa the flu, right? And these are all vaccines that came about, were tested in the same manner that these vaccines were tested and administered to help prevent, from a population health standpoint, harm and loss of life, right? So it's no different from what we've done, what we've seen for decades ago. It's only that in this scenario, right, we've not seen this level of pandemic for several decades. The MARS and the SARS of 2003 and afterwards didn't hit at the level that we're seeing coronavirus hit from a population effect standpoint. And that's why, we see and it's natural to have the back and forth around, is this something we should be mandating, right? But again, the courts have shown this is not new. We have precedents for mandating vaccinations for schools, for universities, and the only difference now is every individual getting vaccinated now is not applying for public school, right? But if you send your kid to public school, they will be vaccinated for all the other MMR, for rubella, right? Measles, mumps, right? Those are things that are in place, have been in place, and is legal. And this falls under that. EEOC says it's legal to do so, and so we're likely not going to see any override of the mandate from a legal perspective because of the precedents that we've seen for decades ago.
Okay, next question. What are the reasons, legitimate reasons for employees to be exempt from vaccination? Not religious exemptions, but legitimate medical reasons. And should employers require a doctor's note? You mentioned getting a note from the doctor after vaccination if there is a complaint of symptoms preventing return to work.
Yeah, absolutely. So two different issues there. So for exemptions, yes, we believe, and our practice has been that if there is a medical indication to which an individual can't get vaccinated, we would like their primary physician to weigh in on that, right? And then we'll review that to make sure that it is consistent with best practice. And if an individual does not have involvement or his or her physician, then it calls the question, what is the underlying condition, which would potentially be an unknown, and then how is that condition really impacted by a vaccination? At this point in time, there are very few contraindications to being vaccinated, right? Because the risk profile has been shown to be very low for any side effects that would have untoward outcomes for an individual. With that being said, there still will be scenarios in which a primary care recommends against vaccination because of ongoing treatment. We've seen that and have reviewed those scenarios, such as an individual undergoing chemotherapy for cancer, right? Or undergoing immunotherapy for other underlying conditions in which introducing the vaccine would cause potential harm and risk because of the immune response for that particular individual. So that's the level of granularity that we've required to support and sign off on a medical exemption. But it makes sense, right? We want to make sure we're being accurate in our understanding of what's risky for an individual because of pre-existing condition and what's not. Risk of we've seen the data now, and I know there's still opinions out there, right? But we've seen the data now from ACOG regarding pregnancy and expecting pregnancy, and the vaccine is having no impact to a woman's fertility or expectancy of pregnancy. And so it's on us as the healthcare EHS professionals to communicate that data so that we put people at ease around getting vaccinated, and so that we don't see a flood of exemption applications for things that are not indications for the exemption. Actually, Yale School of Medicine, Yale University has put out a really great list of what's permissible and what's not permissible for exemptions. And it's succinct, but comprehensive in that it helps individuals, the employees at the university there, understand should they even apply for an exemption. And accordingly so, they've seen a decrease in applications for exemptions once they put this information out there. So we can send everyone on this webinar a link to that document. It's in the public domain, but it's really good at distilling what is and what is not appropriate for a medical exemption.
We'll make sure we include that in the printed version of the Q&A when we post it. Yeah, because I'm thinking about really common underlying conditions like diabetes, hypertension that we see in a large percentage of the working population.
Sure.
But I haven't heard that those are reasons why you shouldn't get vaccinated.
Absolutely. So to the opposite of that, we've seen that those individuals are the ones with pre-existing conditions that should be vaccinated first and foremost, right? Because those are risk factors for poor outcomes for a case of COVID-19. And so it's clear that, again, those are not indications of exemption, but indications of being first in line to get vaccinated, hopefully, to prevent loss of life, obviously, but severity of illness, hospitalization.
Which is what was originally recommended when they first started doing vaccinations for the elderly population, essential workers, and people with certain underlying medical conditions.
Absolutely.
So that's still the practice.
Still
okay,
the
let's
practice.
go on. Let's go on to another question. Do we anticipate the CDC updating their face covering guidance based on the federal requirements for vaccinations?
We do, but it will only be after boosters, right? And this is 100% Dr. Harris trying to prognosticate on what CDC will likely do. And it's because of this, right? It's because of the data. We know that transmission risk is not mitigated substantially by being fully vaccinated. All right, breakthrough transmission is happening across the board. We have I've spoken with one employer that said 70% of their cases are in the fully vaccinated population, right? And so we're seeing the Israel data play out, where only 39% of people are protected from transmission after being fully vaccinated, and that is why individuals still need to mask up. Still need to practice social distancing as much as possible, and why we believe CDC will not change their policy on masking up, recommendation at least, until we have more Americans vaccinated with the booster. At this point in time, we're just at 10% of the population having received their booster. And so obviously we'll need to be an order of magnitude higher than that before we can get the protection at the level of 93% that, again, Israel data has showed us for the Pfizer vaccine after a third dose, and in a scenario in which we can unmask and kind of get back to life as normal. So unfortunately, we're still stuck in this weird universe of masking up and doing symptomatic tracking, because fully vaccinated individuals are still able to contract and transmit COVID. Albeit you're not going to, this is the silver lining, right? If anybody can speak to it, but you're not going to be in the hospital, and you're not going to die from COVID from the odds perspective, right? 88% and 92% respectively for prevention of severity and hospitalization as a result of your fully vaccinated status with 2 doses. But we know that you can still transmit, and that's what we need to prevent by masking up.
Okay, We're looking for advice on booster shot management, recommendations for employers, and updates on natural immunity considerations. Is there any more research news related to that?
There's just additional data showing that those who have recovered from COVID-19 are and then get vaccinated are in a better scenario from an immunogenicity standpoint, immunocompetence standpoint, than those individuals who have only been vaccinated without previous infection, right? So it's clear evidence that you're better off getting vaccinated after you've had COVID-19 for sure. All right, and we know that the waning immunity of those who have had natural immunity is still present, right? I know there's been some suggestion that those who have recovered from COVID-19 are good for up to 12 months. That is not the perspective of preventing, again, another contracting and transmitting COVID-19. It is the data that shows that some will often have memory B cells in their bone marrow, right, for up to 12 months against COVID-19, but that doesn't correlate. There's not enough data that correlates that with being protected from additional or subsequent infection from COVID-19, right? And so we're seeing the same phenomenon with natural immunity as we're seeing with acquired immunity from vaccination, that immunity wanes. There is increasing susceptibility to contract and transmit COVID-19 thereafter vaccination or previous infection. And is why, this is kind of me on my soapbox here, why I believe our focus should be on getting quantitative titers, right? We've talked about this perhaps briefly in past presentations, but having a quantitative titer that can detail whether or not an individual has immunity or not, the same way we do with hepatitis B and other vaccination scenarios, is what we should be focusing our energy on. Unfortunately, there's not a tremendous amount of research, and there is some, but there's not a tremendous amount. At this point, we have semi-quantitative tests that can tell you, yes, you have antibodies to COVID-19, but it cannot tell you that those antibodies are sufficient to protect you from subsequent infection of COVID-19. Quest offers those, LabCorp offers those tests, but again, the utility of them is limited in regards to, should we give a booster? Should we even administer a vaccine to someone who's had COVID, to the point of this question? So we'll stay tuned to see if there's more research that comes out in regards to titers and helping us move forward with getting out of this cycle, because unfortunately, we still don't know how long the booster immunity will last. It gets you back up to 93%, but for how long? And I think in obviously months to come, we'll learn that, but we may be in a scenario in which you need a booster every 6 months to maintain your immunity. I hope that's not the case, but it may be.
Okay, should employers be tracking employees' vaccination type and date and sending them reminders based on the CDC guidance?
I think that is best practice, right? In an effort to help your population get vaccinated, get their boosters when appropriate, and help the organization remain compliant. That is a clear best practice, right? And leveraging an internal system or a third-party platform to do so, obviously, is the way to go. So that you're automating this and you're not having to add FTE just to maintain this type of surveillance program and monitoring, et cetera. But at the end of the day, yes, sending reminders to the workforce will help and encourage, because at the end, we want protection to be the norm, right, in our workforce, that the culture is such that, hey, we're gonna protect the workforce, and that's gonna get us back to normal at the workplace, and hopefully in aggregate back in the communities with high levels of vaccination to get on the other side of this thing.
Could you talk a little bit about requirements for testing remote workers and whether that even makes sense?
So it is a requirement of the ETS, right? We know, and there's been just recently this week additional data from ETS, review from the ETS showing remote work won't get you out of the requirement, right? Let's say you have right at the cusp 100 employees in your workforce, and every person lives in a different city. It doesn't matter, right? You're still under the auspices. You still will be under the auspices of the ETS. And so in that scenario, you have to decide what's best in terms of the strategy of requiring The vaccine, right? Oh, this is the other tidbit that just came out this week as well. EEOC has now supported, as an add to this, that if you are an employer that wants to require the vaccine and not even give the option for weekly testing, right? They support that. There's nothing against that from an EEOC standpoint, meaning you can fire people because they're not compliant with vaccinations. And that's going to be obviously a tough road for many employers to go down, but we've seen it play out. We've seen it play out at the city level, the community level, right? With public workers. We know that there are employers nationally making that requirement and saying it is a requirement for employment. And that is a good strategy to avoid additional costs, right? If we're talking about minimizing the cost and burden for having weekly testing, and eliminating the need to either consider whether you should pass the cost on to the employees, making that requirement, you're vaccinated or you're fired, is legally supported. We've seen it again with EEOC saying you can go down that route and there's no pushback to it. Doesn't mean you're not going to be, in a lawsuit about it, but it does mean that you'll likely win the lawsuit against any pushback from employees. And it is going to be the most cost-effective, perhaps, approach to being compliant with the ETS. So at the end of the day, home tests for those, back to the question, the home test for the remote workers is what we've seen in terms of practice from employers that have a very distributed workforce, and has worked well for them to test on a weekly basis as we deal with the ETS.
Okay, a point of clarification on once the ETS is in place, we know it's an emergency temporary standard. The question is, once it's in place, what will be the protocol to remove the standard, or will we have to live with this indefinitely?
Unknown, right? At this point, in terms of my understanding or my purview of expectation from the OSHA standpoint, right? We know that ETS will not be ETS in perpetuity, but the opportunity for OSHA to adopt it as a standard in perpetuity is there. It's clear, right? If we're marrying that with the expert opinion around COVID, it's likely to be in place for at least all of 2022, right? In terms of a standard, because we know COVID is not going to leave us or become endemic before then, right? And so this mandate, whether you like it or not, or whether you agree with it or not, from its intent is to help us deal with COVID from the loss of life and severity standpoint, as well as limiting transmission to the best extent that our program can with vaccinations. So with that being said, again, we know that there will still be a significant population in the US that will be either unvaccinated or have waning immunity or be naive to COVID-19 infection and be susceptible. And that's, again, something that everyone is anticipating for all of 2022 at this point.
Okay, we have time for just a couple more questions. So again, we'll answer all the questions in writing. And if you just check back on our website in a couple of days, we'll have that up for you, along with a link to the Yale resource. How does the ETS address accommodations? For example, under the federal contractor requirements, there's an exemption process. I'm wondering if when the ETS goes into place, if exemptions will have to have a testing component.
Yes. So the ETS information on accommodations actually just today came out and said that the unreasonable burden, right, is the litmus for whether or not accommodating a worker is part of the requirement for compliance with ETS, right? Meaning that if from and it's similar to what we have seen with accommodation classically under EEOC, ADA, et cetera, right? So it's up to the employer to determine whether or not accommodating a worker that is requesting, and so the issue, let me back up here. So the issue, particularly for accommodation, right, is the request of workers who have been working remotely to not come back into the office because they claim it will increase their risk for COVID transmission, right? And so we're seeing this starting to play out where there's lawsuits being filed against companies to prevent the company from mandating an employee return to work, return to the office, right? And discrimination as a result of that mandate from the company to return, right? And so from that perspective, if the employer determines it's an unreasonable burdensome, unreasonable burden from a business perspective to accommodate that worker, then they are not obligated to accept that accommodation, right? Or put that accommodation in place. And so we'll likely see that play out for the testing requirement as well, in terms of these workers filing suit to avoid this mandate. And again, from the looks of it, the EEOC is going to side with the employer from an unreasonable burden perspective.
Okay, just one more question. It's actually two questions, but they're both about paid time off. Can the paid time off be part of the employee's normal sick time, or does it have to be separate? And the second question is, for paid time off requirements, do we need to offer additional PTO or state sick leave days, or can they use existing banks?
So as of right now, that's an unknown in the details of the ETS. And it's an issue that I believe the ETS will not specify, meaning that it won't prohibit you from including paid time off in the existing bank or in existing PTO time, right? As long as you as an employer are providing the paid time off for COVID vaccination and any repercussions of the vaccination from a side effect profile. Now, we've seen, obviously in the past, the paid time off for individuals who contract COVID-19 as a potential workplace and even community transmission. But I believe we're unlikely to see that as a part of the ETS in terms of the specificity of how to incorporate that paid time off, so that employers won't be burdened with having to provide an additional to what's existing.
Okay, well, we're out of time, and you were right, Dr. Harris. We had a lot of questions. We couldn't get to all of them. We had over 30 questions plus what we got in the chat.
Yeah,
so,
well, I'm glad we did this format to help with that. You know, every now and then
we might want to schedule a special webinar in between now and December 1st to revisit this once the ETS is published and the lawyers start chiming in, and there's going to be a lot in the public domain about it. So perhaps we should consider doing that before Thanksgiving.
I think that's a great idea. Perfect.
As long as you're willing.
You know it. I'm willing and able. Hey, we can go back to weekly if we need to, you know. So yeah, I'm glad everyone.
I can't believe it's been almost 2 years since the pandemic started. We're going to be seeing, second anniversary information coming out soon. So it's never ending. There's always something.
Yeah.
I just want to thank you again for all your helpful information today, and to our audience for joining us once again, our loyal followers and anyone new attending for the first time. So we'll see you next month, and we'll let you know if we schedule an interim session, which I think would be a good thing to do. Thank you, Absolutely. Dr. Harris.
Thank you. Thank you, everyone, for joining. And as always, stay safe and God bless.